exit via the ante-room and down the main steps and assemble outside the front of the town hall. Toilets, I can never remember where all of the toilets are. I know the gents are through there. There's a gents through the ante-room, there's a gents just round the corner there. And ladies are opposite the, is it reception room A? Or, well, I think it's the first one anyway, yeah. So I think that's housekeeping. Apologies. Okay, thanks, Jenny. Are there any items of... there are no items that I can see that require exclusion of the public and the press. Does anyone have any declarations of interest in any item on the agenda?
Yes, Chair. My son is a user of the home care service, which obviously we have to pay into, so I'm just declaring interest.
I imagine that's not a significant interest. It doesn't disbar councillor from taking part in the debate. No, okay. Sorry, I will deal with item 6 first. Public questions and petitions. We have no public questions or petitions. Okay. So, over to Greg, if you'd like to present your report and some good questions for debate will be taken after that. Thank you, Greg.
Right, thanks, Chair. I shall do the appropriate mandatory training to get recognised, I'm sure. So thank you for the opportunity. I did a working brief. I wrote it about a week and a half ago. Some things have changed since then. So I'll take the working briefing paper as read, but I'll pick up some of the key points and I'll update the committee on what has changed as I go through. So epidemiology first, nationally and internationally. Sheffield is below average in the epidemiology right now. That's varied throughout the course of the pandemic, but currently we're a good way below average. Rates in the southwest are still quite high. Nationally, rates in children aged 18 or more are coming down fast, and I wrote this a couple of weeks ago. Was that the half-term effect? We're well beyond the half-term effect now, so it's a real impact, and rates in children are coming down quite fast, actually, and that holds true in Sheffield too. Older people, we have been boosting from the high age groups downwards, and I'll comment on numbers and coverage on boosters in just a minute. Boosting, the booster vaccination program is having a definitive effect. There's no two ways about that. You can see that with the naked eye in terms of numbers. The tricky thing is the middle group, the youngish working age adults, and some uncertainty where that's going to go, both nationally and locally. And largely static rates at the moment, and may go up, may go down, but we're certainly going to boost. We're going to be in the territory of boosting people from age 40 plus, and are doing that now. Internationally, lots of commentary in social media, in particular. Most of it's just plain wrong, to be honest. It's really hard to interpret what's going on internationally, comparing this country to other countries. Testing rates, bed capacity, timing and nuances of various measures, including vaccination, but also others, and the timing of the epidemic curve makes it really, really difficult to interpret. But people that say it's all terrible in the UK, look at Europe, are wrong, plain wrong. And now you could see it in Eastern Europe 3 or 4 weeks ago. You can now see it in Western Europe. We're on probably the flat and the downward slope. Western Europe's definitively on the upward slope here. So, and what's that space with interest? Sheffield, a week and a half ago, case rates were below 300 per 100,000, and as I said in the paper, it's impossible to say where that will flatten. I thought then it would sort of just oscillate around somewhere between the 250 to 350 per 100,000 over a week mark. That has proven true. We've gone back up above 300. I think yesterday it was 320 per 100,000. That won't change much now. I don't think it will change much over the course of the winter. The one prediction I would make is don't make predictions because they're always wrong, but I don't think that will change much over the course of the winter. Most of our cases are in secondary school age. The mixing pattern is pre-pandemic. We've seen a 25%, nearly 30% coverage in secondary school age kids of the vaccination programme, and significant numbers of kids have had it now, so there's a reasonable chunk of immunity in that population. I think we'll now see the downward slope, and we're seeing that in the data now, downward slope in secondary school age children. It's quite a rapid fall at the moment. Primary school, we're not vaccinating that group, and interestingly, if you look at the true population prevalence survey, so the ONS infection survey, not actually that many cases in primary school age, and nobody knows why that is anywhere to my knowledge. And it's worth me saying that most of the case rate is in school age, particularly secondary school age children. Harms are low to negligible. It's not zero, but low to negligible harms. A little bit stacking up through parent age. Older adults is obviously where the concern are, because this is the group that's been poorliest, most susceptible to severe illness. And timing proximal to when you had your first and second vaccination is the issue. There is waning immunity, hence the need for the booster programme. And what we're seeing is we've got booster coverage of more than 65% in the over 60s now, and more than 40% in the over 40s. We've only just opened it to the over 40s, but certainly more than 65% coverage in the over 60s. That is having the desired impact in terms of rates of hospitalisation. There's no two ways about that. That can be seen nationally, it certainly can be seen locally too. Hospital. It's worth saying that there's a lot of pressure in the hospital system. Bed occupancy is increasing steadily, not quickly. Both general bed and intensive care high dependency unit. Mostly clinically vulnerable, immunocompromised and unvaccinated, actually mostly unvaccinated, if I had to call it one way or the other. Average length of stay is certainly shorter than it was. And as I say, mostly the non-vaccinated cohort, but not all. There are some vaccinated people who are still poorly enough to be hospitalised, but mostly the unvaccinated. I should say that it's not just the hospital. The totality of the health and social care system is under exceptional pressure at the moment. Sort of the depths of a bad flu winter type of pressure in mid to late November. And that's not very often that pressure. And what you see in the media, both locally and nationally, is definitely true. And I'll come back onto that towards the end. Very few deaths, one a day from COVID. Clearly not good if you are that one, but certainly, again, the vaccination programme is doing what it is expected to do, because the current case rate, had we had an unvaccinated population, would be in the 20 to 30 deaths a day type of territory. We're seeing, very, very, very much less than that. The why have we got what we've got? Largely waning immunity. We started vaccination much earlier at a big scale than most of Western Europe, and therefore we've seen a much bigger early winter peak than Western Europe. Large amounts of indoor mixing. Household transmission, within household transmission is where most of the transmission happens, has been through the course of the whole pandemic, remains true now, from people that we know, not from strangers outside the house, it's from people that we know within the house. That's always been the case. Large number of people attending gatherings, that said, and there is some transmission there, and the percentage of people not wearing face masks in enclosed public spaces is quite high. I'll be on the train later, and I'd be surprised if it's more than 10%. I'll have mine on. Future, winter. Never make predictions. They're always wrong, but the one prediction, and I've made two predictions now, but the second prediction I'll make is that the winter will be exceptionally difficult for the health and social care system, not just the hospital. That matters, obviously, for all sorts of reasons, but most importantly for the care of other people that may get delayed. So there is a big pressure on the hospital to deal with the elective care backlog from the pandemic. That's going to be exceptionally difficult for the hospital in a time of very high pressure from some COVID, but actually it's the everything else that's happening that is probably much more concerning. It's hard to know what will happen over the winter, other than it will be an exceptionally difficult winter for the system, as I've said, and this is before flu starts, and flu is a worry for me this winter. Last winter, what was flu? There was almost no flu last winter, and that was unheard of. We were all wearing face masks, we were all washing our hands regularly. We had really high rates of vaccination, and it was a good match. The virus to vaccine match was a good match last year. This year, we didn't have flu last year, so there's less residual immunity. Some queries about the severity of the strain this year, we don't know. Some queries about the vaccine to virus match, we won't know until we sort of come into contact with flu. But the general sense of those virologists and others that are making predictions is it could be a bad flu year. That significantly exacerbates the position that the NHS and social care is in. Plan B. I don't know if or when the Prime Minister will execute Plan B. It's a document that's very light on tactical detail. It's a signalling document that it's all not over, and it's definitely all not over, but there's not a huge amount of tactical detail in Plan B, and that may be because it will be worked out closer to the time the Prime Minister chooses to execute it. The things that we think would be in Plan B would be mandation of face masking in enclosed public spaces. One, that in itself won't be the thing that swings the epidemiology. It'll have an impact, but it won't be the killer intervention that will swing the epidemiology. And I think it's probably too late to shift back to mass face mask wearing. It was always impossible to enforce. It's a behaviour that we want 600,000 people to adopt, and it's impossible to enforce that, and we don't want to, nor can we turn bus drivers into policemen or enforcers for all sorts of reasons. It was always on the basis of consent and willingness to wear a face mask, and I think we've lost that actually nationally, not just locally. Second intervention within face mask within Plan B would be work from home if you can. That will be the thing that has the largest impact and effect by a long stretch. Obviously that works really well for people that can work from home. I can work from home, have been for nearly 2 years now. It can't work from home if you work in a warehouse. So that, we just need to be mindful of that. And vaccine passports may be a part of Plan B, I don't know that. I don't think that will be the thing that will make, the purpose of vaccine passports is to push vaccination coverage even higher. It's a controversial measure, and I'm not sure it'd be the most effective measure, and there'll be an argument about it, I think. Don't know the threshold for Plan B, nor the timing of Plan B, but the threshold will be about NHS and social care pressure. The thing that's most readily measurable is what's happening in hospitals, but as I've said, don't just focus on what's happening in hospitals, and it'll be the cumulative pressure of all that's going on in the box that is the NHS and social care system. But I don't know the timing, or if indeed, if it will happen. Vaccination. Rollout continues. The rollout of primary vaccination, dose 1 and 2, has slowed. We've got 70% of the eligible population vaccinated. Still the leading of the core cities, but not the best in Yorkshire by a long stretch. 70% fully vaccinated. Now 70% of people aged 12 or more fully vaccinated means 30% aren't. There are still tens of thousands of people who haven't had the first 2 doses, including lots of elderly people, and that's the thing I most worry about. it's hard to know what we could do that we aren't doing. This isn't for lack of trying, but it is really difficult to know what we are doing that we can't do. There is a gap between the east and the west of the city. There's a gap between BAME populations and white populations. Not as bad as I had feared by a long stretch, but there is a gap. But as I say, it's hard to know what we could be doing. 12 to 15 programme continues. I think all secondary schools will have had a vaccination clinic run there by, I think, the end of this week. It might be the end of this week or the start of next week. That continues. The news on second dose for 16 to 17-year-olds was welcome. I fully support where JCVI are on that. And there's a high degree of pressure on the NHS to accelerate that programme. They're going as fast as they can. There are some practicalities that are impeding it, but they're going as fast as they can. The booster rollout continues to happen, absolutely critical. That's accelerated massively in the last 2 or 3 weeks. So last time I looked at the data seriously, we were on about 30% of the older adult population, 65 plus vaccinated. It's now well more than 60%, closer to 65%. So that's accelerated massively in the last few weeks, and credit to those in the NHS and our own organisation and in the voluntary community sector that have helped make that happen, because that's a collective city effort. In order, the groups I worry most about in terms of vaccination are those adults, particularly older adults that haven't had dose 1 and dose 2, they're most likely to be seriously ill. Then boosters in the order that we're going, which is an age-oriented order, and then children's vaccination is last on my priority list. But if the purpose of vaccination is to save lives, the ordering is certainly my priority is according to that. Implications and interventions for what we are doing as a city, the basic machinery that we've put in place to sort of the comms, the support to testing, the support to vaccination, the support to identifying and managing outbreaks, the enforcement interventions. There's a well-developed set of machinery that's all working pretty well, actually, and there are no major strategic or operational problems in that, and it's working pretty well. And odd time to say this, but we will be beginning to think about the exit strategy for that, with a view to having it stood down by March next year. Things may change, but I'm anticipating that the situation with regard to COVID will not be as it is now by March next year. So we're beginning to think about the exit strategy for that. School interventions, it's worth me dwelling on very briefly. We are definitively working hard to maximise the number of days in school kids have. Because education has been messed up enough during waves 1, 2 and 3. All up, schools are low-risk settings, definitively low-risk settings. We continue as a city to have lower school-age case rates than certainly the rest of South Yorkshire and most of West Yorkshire, and I think nearly the best in Yorkshire. And that hasn't happened by magic. It's happened because lots of us have worked really, really hard, including schools. Heads have done an amazing job in this space to manage outbreaks and to manage COVID risk in their settings. There are cases, I've said that early on, but comparatively, the city's doing pretty well in that space. We've got a well-developed and pretty robust approach to managing outbreaks when they occur. They do occur, and a pretty well-developed case to sort of managing COVID risk assessments and what the mechanisms are for lateral flow device testing, etc. And that machinery works quite well. Worth saying that the number of outbreaks is diminishing really quite fast at the moment, as is the number of cases. So. Overall messaging from me, it's going to be an exceptionally difficult winter ahead for the NHS and social care. What you see in the media is true, definitely. There are not easy fixes. All bits of the NHS and social care system are working exceptionally hard to provide care for those who are acutely poorly with COVID or any other respiratory virus, but all of the other stuff that the care system does exceptionally well all the time. My consistent ask of the public of Sheffield is to remain cautious. As much as I want to say it is all over, it's not all over. It might be all over by spring next year, but it's not all over. And the sort of the basic messages are, as I say in those videos, week after week after week, get vaccinated, wear a mask, wash your hands, etc. So I'm going to stop there, and then hopefully you'll have some difficult questions which I may or may not know the answers to.
Thank you, Greg. So I'll open it up to members for questions. Sorry, can't see what that is. Oh, Francine.
Thank you. Thanks for that presentation, Greg. Thanks for letting us know about the boosters. It's really good to know that over 60% of over 80s have now received their booster. I'd just like to ask a bit more about the vulnerable and immunocompromised. I know I've raised this previously, and I've spoken to some more people in the city, and there seems to be quite concerning level of chaos over the identification of both vulnerable and immunocompromised people. I spoke to a man with severe leukemia earlier this week who had still not been contacted for a booster, and also 2 carers of an extremely immunocompromised older man with multiple sclerosis who had also not been contacted for a booster. And I'd just like to know more about what's possibly going on here. I know that in the first rollout that primary care was responsible for identifying people in need of early vaccines, and that this time it seems to be NHS England. And I think there seems to be 2 issues as well. One in the identification of these groups of people, but also there seems to be a lot of confusion in terms of the messaging that they're receiving. So I spoke to people who've received text messages from both NHS England and their GPs that have been really confusing, and they just haven't been able to access vaccines as well. I know the blood charity, I can't actually remember the name of it now, Myeloma UK, I think maybe. They've put out some communications saying that they are absolutely inundated with callers of immunocompromised patients who are unable to access boosters, and I've also spoken to a specialist nurse in Sheffield who's confirmed these issues. So I'd just like to know a bit more about what's going on there. It seems to be partly a national issue, so I'd just like to know what we can do locally to sort of counteract this and do whatever we can. Thanks.
Thanks, Councillor Johnson. Quick thoughts. One, the NHS needs to respond to the letter that you put to it, and they've asked me for comments on that. But it is their programme, so they need to provide you with a detailed response to some of that. 300 people who are immune compromised have received their 3rd primary dose. What I don't know, and I asked this question this morning, I've not had the answer to it yet, is what's the denominator? How many haven't yet? So as soon as I know the answer, I shall make sure you know. I think it's fair to say that the national comms was a bit messy and chaotic. Locally, the CCG worked with primary care to identify the cohorters who should be eligible for a booster, using GP information systems with a specific set of clinical search criteria. I don't know how many people were identified in that search and or what communication happened with them as individuals, but that should have been happening of individual by individual. It's a complex, fiddly message. Who should be eligible for a 3rd primary dose versus who should be eligible for a booster. So boosters is basically anyone aged over 40 and younger adults who are normally eligible for flu vaccination. 3rd primary dose is specific and hopefully very small numbers of people, of which 300 people have had their 3rd primary dose, who are immune compromised. But doing that in a public-oriented comms messaging, it's turned messy, actually, and I don't think we've done a very good job on it, to be honest. Three things I will commit to. One is finding out the number of people who are identified as immune compromised, and I know that the numerator of that equation is 300, I don't know the denominator. And secondly, who has had what communication as an individual, and I'll make sure that is in the response to the letter that you've put to the CCG. The draft of it floated around my inbox the other day.
Thanks.
Ruth, Councillor Ruth Milson, and then Bert.
Thank you, Chair. I've got some questions around point 6 6.6 in your report, page 29. Firstly, about GPs, you've mentioned GPs, ambulances and A&E are seeing record numbers of patients. So around GPs, and there's been an open letter that's come from the CCG, from some of our senior doctors, written, addressed to the people of Sheffield, explaining difficulties in getting GP appointments at the moment. And I think that's a really good thing to have done, to reassure people that, you know, that there's awareness in the system that there are difficulties, and to explain some of the reasons for it and suggesting some of the ways that people can access their GP. But I wondered, what's the current situation in Sheffield regarding patients getting timely GP appointments? Is this better or worse than usual for this time of year, if you know that figure? And data from May this year gave a number of 8.7 days as the average wait time for a non-urgent face-to-face appointment. And I wonder how we're doing in Sheffield against that figure. And then, sorry, I've got two more questions. Secondly, it is good to read in that open letter that many Sheffielders are happy with phone and video consultations. And I think it's good to see that in print, because it does encourage people that that system is one that works, if they feel comfortable with it. But I wonder who's providing those consultations. Is it the patient's normal practice GP, or is that being provided drawing on the PCN's wider hub service, or is it even being provided externally to our practices? And are you confident that IT disadvantaged patients are still being seen in a timely way, and there's no inequality of access between those who are able to attend a phone or video consult and those who can't? And finally, just regarding your message here in 6.6, that there is an exceptionally difficult winter ahead with other winter illnesses besides COVID. Is there a comms strategy in place to encourage people and workplaces and public venues to exercise the best possible hygiene practices to prevent the spread of other illnesses as well as COVID? Thank you. Sorry, that's quite a lot, sorry.
Thanks, that was a long set of questions. I'm going to have a go. In reverse order, on the comm strategy, yes, that's in place, and there's an extent to which we're sort of partly preaching to the converted, because there are no new messages here, and you'll have seen my videos. I largely say the same thing every week. It gets a bit dull. So sometimes it's difficult to think of new things to say, and what we are finding is that the big C comms, where you carpet bomb a whole city with comms, just doesn't cut through anymore. It cuts through with those that are listening, but it doesn't cut through with the people that we really perhaps want to get to. So we've flipped the comms to a very localised approach, working with and through community and faith leaders, etc. And that served us quite well with the vaccination programme. So in short, there is a comms strategy along those lines, and use the right kind of care appropriately. It will be moderately effective. It's not going to solve all of our problems by a long stretch, but it will be what it will be, and there is a strategy in place. Phone and video exclusion. Yeah, I think it's fair to say that primary care is acutely aware that there are significant numbers of people who just don't want to use phone and or video, and face-to-face appointments are available. And we all hear about the times where it's difficult for people to get a face-to-face appointment, but the reality is there are lots of face-to-face appointments, but nobody ever tells us about those. So they are available, and GPs across the city work very, very, very hard to make that available. On the sort of does the data support the most people prefer a non-face-to-face? Yeah, there's something called Ask My GP, which I think is a live daily sample survey of, I think, 150,000 people nationally. It's not a Sheffield thing, it's a national thing. And it's very readily available. They make the data available on various forms of social media. And from memory, when asked what their preferred mode of consultation is, 90% say they want remote, i.e. Online and or phone. What we try to do in Sheffield is, I think 85% get get remote. So our GPs on a triage say, actually, I prefer to see Mrs. Smith, even though Mrs. Smith wants a remote consultation, given what's going on, given the GP can see Mrs. Smith's clinical record, he or she would say, I want to see Mrs. Smith. So there's a sort of almost a flip the other way. Clinical decisions are made to not honour people's first preference because the GP or the practice nurse wants to see that person face to face. You know, that won't always work. There's no two ways about that won't always work. But there's significant efforts are made to honour what people are expressing their preference for. And for me, I absolutely prefer non-face to face. But two, sometimes decisions are made to go the other way, and that's kind of done on an individual clinical basis. On the 8.7 days, I genuinely don't know. I don't know how our data compares. I don't think we've got very good data on appointments. Measuring appointments in primary care is really rather difficult. And what counts as appointment varies a little bit. It's worth saying, how does the level of demand compare? I was on a call yesterday. The Health Care Partnership Board with the chairs and chief execs Kirsten Major, Chief Executive of the Hospital, drew attention to a Royal College of GPs report that said, and this is nationally, and I'm sure this holds true locally, that the RCGP had said in September just gone, there were 2 million more appointments given to patients than September 2 years ago. Obviously, last year was an anathema because we were in the depths of wave 3, I think it was this time last year. So look back 2 years, there were 2 million more appointments in the September just gone than 2 years ago. And one of our GPs was also on the call, said in his practice he'd done the sums and there were 80% more appointments today than there were this time, or this week, than there were this time 2 years ago. So, so the demand is up. Our GPs are trying exceptionally hard to manage that demand, and by and large doing a very, very good job at that. And what's really happened is that demand has gone up. It has been exacerbated by COVID, but the resourcing into primary care just hasn't kept pace, actually, and has almost gone the other way. So we need to think about that as a national problem. That's just not a local problem. So all up, our GPs are managing as best they can in very, very difficult and very, very high demand circumstances. Did I cover all of your questions? I think I did.
I think so, except that just about people who can't access their GP by phone or video. It's not just preference, people who can't. Are they being seen in a timely way with a face-to-face appointment?
As far as I know, I can't guarantee it happens in a timely way for every appointment, but as far as I know, that is the case.
Thanks very much.
Okay, Bernard. Thank you for coming along today. My concern is about independent small businesses, particularly shops. Is any advice being given to them, or is the Federation of Small Businesses, as they talk to you? Obviously, when you've got an independent business, the whole business depends on one or two members of the staff, as it were, and the whole thing could collapse. So we need to be particularly careful about that. Is any advice being sent out?
Yes, it's probably not the area that I could speak terribly knowledgeably about. It tends to be done by the business support part of the council, but yes, I think they've spent the last 2 years providing maybe not tens of thousands, but certainly thousands of pieces of advice to small businesses around keeping COVID safe and what grants are available to keep businesses open. And there's a team of people that do that. It's not something I'm terribly close to because I tend to spend most of my time on the sort of the healthcare consequences as opposed to the economic consequences, but very concerned about the economic consequences, and I think we're doing our best as an institution on that one, as are the Chamber and as are other business institutions.
I was just wondering if there were any posters, as it were, that small business owners could put in their windows encouraging people that go into their premises to actually wear a mask. I mean, this is happening in Walkley, for example, but it would be nice to be seeing it done more widely.
There are posters, and I think they're out there. I see plenty of them out there, so I'll test whether or not there's a view that is kind of worth doing another round of that. I agree with you. Keeping small business going is mighty important for all sorts of reasons.
I wanted to ask about care homes. Sorry, snuck up on you. So I was just wondering whether or not infection rates in care homes were reflective currently of the sort of general population, or whether we were seeing any sort of outbreaks or higher rates of infection within care homes. And I guess linked to that, what support care homes were currently being given around infection control, and possibly this creeps over into Alexis's territory slightly, but sort of how that was being balanced on an ongoing basis against people's sort of, you know, sort of rights to liberty, visits and so on, which we know is still impacted differently in different settings. Just wondered if you had any insight into where we were at with those things.
I'll start and then I'll let the boss carry on. Care homes, we're seeing cases, and we keep a very, very close eye on cases. They largely reflect the age-specific rate in the community more broadly, and much lower than they were this time, say, last year. So one reason why that is, and one reason alone, huge vaccination coverage, well north of 90%, in residents I think closer to 95%, Alexis will know the numbers offhand. That's doing the job it said it would do. It's keeping people away from being significantly poorly. It's massively reducing but not eliminating the transmission of the virus. It's still possible to transmit. So the vaccination has done its job, but there are still cases. People in the main significantly less poorly than they were, and way less cases. Outbreaks, one or two from time to time, but really the exception rather than the rule. Very well developed set of machinery to manage the outbreaks now. What we see happening, I see it happening on NHS premises too, minor lapses in PPE and infection prevention and control because staff are tired, to be honest. And I've put on record the staff in care sector, not just homes, have done an amazing job. But people are tired, and minor lapses in the context of a very infectious respiratory virus, that's how it gets in. So we're continually kind of redoubling our efforts and looking at how did this happen and what can we learn both as the individual home where an outbreak happens, but with the sector more broadly. Support from, I say Public Health England, the UK Health Security Agency doesn't quite trip off the tongue yet, their job is to do the risk assessment and to provide the advice. Infection prevention and control nurses, which are CCG employed, are very pivotal in that, as are some of my team in terms of the mechanics of managing the outbreak, and some of Alexis' team are also involved in that too. On the outbreak prevention, again, we've got a pretty high functioning set of machinery to work with the sector to continually reinforce the need for prevention of spread of this virus. I'll come on to the caveat, not necessarily caveat, in just a sec. With the IPC nurses and with some of Alexis's team, one thing it's worth noting is that what works to prevent COVID will also work to prevent flu. We're coming into flu season. We've got pretty high flu vaccination coverage. Could be better, but pretty high. And also works to prevent norovirus. It's not quite norovirus season yet, but norovirus, again, is exceptionally infectious. Probably isn't going to kill many people, which is good news, but what happens when it gets in is that you knock out whole cohorts of staff, and wards close and the like. And so the washing hands, wearing face masks, etc. message also works against norovirus and also works against flu. So all up, the machinery works quite well. There are some cases, not loads, and there are some outbreaks, but more the exception rather than the rule, and they're managed by to the letter of the book. Care homes are high-risk settings. There are other settings that I'm very much less worried about an outbreak in. A school is one of them, and we do manage outbreaks in schools, but outbreaks in care homes are high-risk settings, and therefore we manage it by the book and we manage it fairly assertively. Alexis, what did I miss?
So I couldn't have said it any better, Greg, first of all.
In terms of the infection rates in care homes, we have a weekly dashboard in which we review and monitor rates, and that was something that we put in place last year so that we're keeping track. And as Greg says, you know, they've continued to go and reduce down, which is good. What we have in place is support from quality teams, both across Sheffield City Council and also NHS Sheffield Clinical Commissioning Group, and very much work together particularly around infection control in care homes. We've also got a care home support group which oversees the response to any outbreaks, and that's a multidisciplinary group that consists of colleagues from NHS England, Public Health, and across the CCG and also across the SEC. And one of the things that's been really helpful about that is helped us to gather intelligence but also have a direct response as a whole system, but ultimately to support care homes, which has been really helpful. Equally, we have an ECHO programme that's been in place by St Luke's, and I thought it'd be helpful to mention that because St Luke's have done a really fantastic piece of work in supporting and providing education across the care home sector, and it's one of my key priorities to continue to go and support the work of the St Luke's and the ECHO programme to particularly as we go into winter, and particularly as we continue to work through the pandemic, that we absolutely have a support and a focus for all care homes across the city, building upon what we've got.
Thank you. Can I just pick up on one more sort of bit there, which was about sort of how care homes, in that context that you've described, are sort of making decisions still about that there are still some restrictions we know on visiting within different settings, and what sort of oversight there was on that in terms of balancing you know, potential deprivation of liberty against risk.
It's a really great point, Lucy. For me, what's been really important is that we promote the well-being of residents of care homes, and as part of that, we have provided the government guidance around two care homes in the city, and each care home will make, because they're independent, will make their own risk assessment based on that. But again, one of the key things for me is about how we continue to strengthen our approach. And for me, what I've actually done is over the last few weeks has been allocating dedicated leads so that we can continue to balance the focus on infection control with also the well-being of residents of care homes, and very much the interaction with family members, which I know is really, really important, particularly as we come into Christmas time and we come into winter time. So it's a very good question, and what I'm going to do is make an offer to you to be involved in part of that work as well, so we absolutely make sure that people's views and voices are absolutely core to what we do going forward.
Okay, Lucy. Do we have any more questions from members? Oh, Lewis, yeah.
Thank you, Chair. Thanks, Greg, for the report. Just on the Plan B, and you said that working from home was the most effective, or likely to be the most effective part of that. What sort of data do we have on the numbers that are working from home still now compared to pre-pandemic that haven't returned to the office? I'm just trying to sort of understand the effectiveness of working from home as a measure now compared to when that was first introduced back in March 2020. Thank you.
Honest answer is we don't have very good data. I can give you a sort of a sense, but it's a sense rather than anything that's based on data. My sense is probably about 30% of those that are working in an office, now I don't just mean council employees, I mean kind of employees more broadly, are back in the office. Significant numbers, 70%, are still at home for some or a portion of the week. And obviously in that, we're kind of, I think it's probably also important to think about the carbon impact of travel choices, and all of those kinds of things are also in the mix. But as I can say, it's just a sense rather than a sort of what's actually happening. We don't have very good data, to be honest, or I certainly don't have good data. It may exist, but it doesn't cross my desk regularly, if at all.
Okay. Just before we let you go, Greg, I have a couple of questions. I think I have a forewarning of this about the Sheffield Joint Health and Wellbeing Board. Last year, the Health and Wellbeing Board commissioned rapid health impact assessments on a broad range of specific themes like education, housing, employment and so on. And back then I was asking what the timetable were for those findings to be presented to the board and to wider elected members, and what influence they might have on other citywide plans. I'm just wondering, I'm not expecting an immediate answer here today, but it is a question I wonder whether you could take away with you. Where we're at with the rapid impact assessments. The second question was more overall question about the Joint Health and Wellbeing Board fitting with the new integrated care framework and the terms of reference for the Health and Wellbeing Board. It's an important question for this scrutiny committee, is how it's envisaged that local Sheffield place scrutiny is scrutinised, basically, how that will fit. And again, I suppose that's an even more difficult question for you to answer immediately, Greg. Okay.
Thanks, Councillor Ayres. As you forewarned me, I've thought about the answer to both, so I can answer both. I'll have a go. So on the rapid health impact assessment, it was anything but rapid. It was a long, tortuous process, and it was done very, very thoroughly. But a voluminous set of work done by many people was brought together in the thing that we eventually call the rapid health impact assessment. It was many hundreds of pages long, and it then got summarised into about 40 pages. Was presented to the Health and Wellbeing Board in 6 or so months ago, I can't remember the exact date, but broadly accepted by the board, with two caveats. One, the board isn't actually a decision-making body. It doesn't have delegated decision-making power from either of its parent bodies, the committee of the council, but also the CCG. So it couldn't kind of accept some of the recommendations. Some of them did require a formal decision. And secondly, there were 170 odd recommendations, and the ability to program manage the implementation of 170 recommendations was a bit limited because we don't have an infrastructure for it. That said, many of the recommendations have been taken forward by the appropriate group of people or the appropriate body. So recommendations that were about the impact on alcohol consumption, for instance, have been taken forward by the appropriate group, and some of them have come to pass. I think there is merit in coming back to the impact of the COVID pandemic, because I think the health and well-being impact will be with us for a generation. The basic story won't have changed a great deal, and I think there's merit in coming back to the impact assessments that were done and socialising them a little bit more widely, because it's the easy thing to say is the Health and Wellbeing Board have seen the report, endorsed it, and it's now done, and I think the board should come back to that. So I shall commit to trying to agenda that in the not too distant future. The second question was about the role of the Health and Wellbeing Board going forward, particularly with reference to the integrated care system, which formally comes into being on April the 1st. All of the indications are in the parliamentary conversations about the white paper before it becomes an act, is that Health and Wellbeing Boards will stay. All of the narrative around integrated care systems is that local is the thing that matters most, and certainly the incoming chair of the ICS is definitely of that view and has said so on a number of occasions. So I think that strengthens the arm and the place of the Health and Wellbeing Board to be the owner of the city's approach to health and well-being. The clue's obviously in the title, of which a component is what the NHS and social care system does, but obviously poor air quality affects health, poor quality housing affects health, so it needs to give due regard to all of those things as well. But I see not much change with regard to the interface between the NHS and the Health and Wellbeing Board, notwithstanding the fact that the CCG won't exist anymore. So we need to give some thought to the organisational mechanics of that from the NHS side of the house. And obviously the council is going to go through a significant change in structure and governance, and that will affect the council side of the house for the Health and Wellbeing Board. So all up, I think I'm going to ask the board in the December meeting, it is very timely to have a reasonably substantial review of the terms of reference of the board and the structure, function and process of the board. I think it would be timely to do that, given all of the changes that are upcoming. Quite the relationship then between scrutiny function and the health and wellbeing board, and whether or not that scrutiny of what the NHS does exists at a Sheffield level or at South Yorkshire level, I don't know. It's being kind of worked through in various places, and I don't know how that one will play out. Genuinely don't.
Thank you, Greg. So, unless members have any other questions or comments on the report, can we note the report? Everybody happy to note the report? And thank you, Greg, and we'll let you go. Catch your train. Thank you. Right, so we said that we would take the minutes at the end, so I propose, if that's okay with members, to move over to Alex's to present the social care update report. So over to you, Alexis.
So, first of all, I just want to say thank you very much for the opportunity to speak today and to provide an update about adult social care. I want to start by apologising for the delay in the report. This was actually due to responding to some of the social care pressures which you just heard about from Greg there. And that includes the procurement of additional care home beds to build capacity within across Sheffield, as well as additional capacity to our workforce and across social care. So I just thought I'd start by saying that to Scrutiny Committee. And before I go into the substance of the report, I just also want to take this opportunity to thank the social care sector, who have been absolutely tremendous during the pandemic and who have absolutely done a fantastic job in trying to continue to go and support people during what has been a very difficult time for the sector. So I just thought I'd perhaps start off by saying that in terms of social care workforce. I feel very proud and privileged to be working with such a fantastic group of people. So in terms of the overview of the report, is my ambition very much for Sheffield is that we deliver excellent quality care and personalised services for communities, for individuals and communities across Sheffield, and very much end inequalities, enable people to live the life that they want to live. In addition to responding to the current pressures in relation to winter, we also deliver a whole range of social care services for people across the city. And that includes people with a learning disability, autism, people experiencing mental health, older adults, and people who are returning home from hospital, as well as young children, young people who are transitioning to adult services. And we have a range of responsibilities that I've outlined within the report to go and do that. So I thought it'd be helpful just to kind of start by providing that overview. Within the report, what I've detailed is really two key points which I think is helpful for the Scrutiny Committee to be aware of. Number one is the implementation of an enhanced assurance framework for adult social care, which is being proposed as part of the emerging Health and Social Care Bill. And that will require adult social care services to provide assurances regarding our impact on people, as well as the delivery upon our legal obligations. And then secondly is to note that we'd also undertake a self-assessment earlier on this year when I came into post, and from that helped us to identify some key areas of priority, and these were implementing a long-term vision for adult social care, a care governance framework which sets standards and enables us to be very transparent in how we are, our performance, a new model for home care delivery, and that was very much based on feedback from people who use our services, a new model for enabling young people to transition well into adult social care services, and to ensure they have the very best start in life. Strengthening our approach to safeguarding and mental health, and developing a workforce plan which values and empowers our social care workforce. And then finally, building capacity of social care workforce across the city to respond to the many priorities that we have, and ensure with that that we enable people to live the life that they want to live and deliver the very best outcomes for the people of Sheffield. We've delivered well so far. We are in the process of drafting the strategy, and that has been very much informed by the views of people that we support so far. And we aim to go out for consultation in between December and January based on what people have told us. Equally, we have drafting a care governance framework which will set the standards, and where we can continue to go and consult with partners and engage with partners on how that should look like for the future. So very much again, it's open and transparent. We have also looked at models for home care, and that's going to be discussed at the Education, Health and Care Transitional Committee on the 2nd of December. And equally, we have proposed some new models for enabling young people to get the best start in life as they transition to adult social care services. And alongside that, we've also developed some work to go and build some capacity across the workforce across social care. And that's both across Sheffield City Council and our commission services, so that we could increase our capacity. And finally, in terms of the inspection framework, what I thought was really important is that we are proactive in response to this, and have implemented an inspection preparation team so that we could ensure that we are in the best possible place once this comes into place. So I'm pleased to say that we have made good progress. Around each of these key areas of priority that we identified, and that very much aligns with the one-year plan that was published by Sheffield City Council. In my recommendations today, what I recommend as three key things is, first of all, is to note that there'll be introduction of an assurance framework for adult social care through the passage of the Health and Social Care Bill. More information is being gained about that, but my second recommendation is agree that regular updates are provided to committee on the assurance framework and our preparations for this. And then third, agree that regular updates are provided regards progress with our change programme. So I'm going to stop there and ask for questions.
Over to members. Questions? I'm just wondering, Alexis, thank you for the report, and we'll come to the recommendations subsequently, but I'm just thinking in terms of in terms of the adult social care portfolio is under, as we're all aware as members, under increasing pressure. I'm just wondering whether we will, as a scrutiny committee, be in a position to look at anything that is, in the pipeline in order to addressing some of the financial, particularly the financial pressures, and also as the strategy develops in terms of rebalancing the care market, whether that could come back as well. So, okay. I'm looking at members. It's the first time nobody's asked them. Bernard, thank you for helping me out.
Thank you for being here today. Thank you. This is very strategic, the work that you're doing, but my concern is the practicalities. You talk about formal relationship with NHS structures. Do you feel what we have at the moment with the relationship of the hospitals we've got in the city with plans for, when people are discharged into various facilities around the city, do you feel that system is working well? I say this because I know on the wards they struggle to find suitable placements for people who need sort of secondary support on leaving hospital. And will that be sort of included when they're thinking about strategy? It just feels, having worked on there for 20 years, It just feels that that's always a sort of a grey area. Thank you.
Thank you very much. A really excellent question. So, one of the key things behind this is a very practical programme of practical delivery actions. And for me, in terms of there's two parts to your questions. How are we working with our colleagues in NHS? And secondly, what's the impact upon discharge? So in terms of our relationships and working with the NHS, we work very closely with our colleagues in the NHS, and that's across all the trusts within the city, plus also our colleagues in the CCG and with our wider partners within the independent sector and the VCF. We have a very good relationship, and what we have is what's called an operational working group with all directors across the trusts and social care, in which we work together to look at how we respond to the very practical pressures that we have in terms of the current winter, plus also the current demand that we're all experiencing as a result of the pandemic. So we have that operational working relationship in place, and it is a very good working relationship, and part of that is very much is problem solving together, which is key. And how we go forward. And secondly, in terms of the demand pressures, is what we have just now is unprecedented. And I say I've worked in social care for a long, long time. I'm not going to say how long, but I'm going to say it's a very long time. And what I have never seen anything like this. It is really a high demand right across all services. And Greg's update really highlighted that today. And what we're experiencing is, although I can say for social care services we are currently providing the maximum level of support, that's actually not enough to deal with the demand that we are facing currently within that comes from all routes into social care, not just a hospital. And so that's why we're working really hard to really find practical solutions, and that includes building capacity across many different sectors. And so it's been very, very practical solution, but these have been done very much as a partnership with our health colleagues and to look at what works. On a very ground level basis, is what we have is what's called an escalation call, and that's where heads of services and service managers meet from across colleagues in the trusts and in the CCG and in social care, and they meet on a very regular basis during the week to look at the issues that's arising and look at what solutions practically they could put in place, so that ultimately we're all working to the same goal, which is to get the very best outcomes for people. And it's been that very much that close working relationship which I think has helped to get us to this point, although we recognise that there's absolutely more to do, and we recognise that we continue to need to find solutions to deal with ultimately what is a demand upon a social care. We are not alone in Sheffield within this. This is a UK-wide issue, and it's certainly something in what's been highlighted through many different routes. So hopefully that's helpful, and if it would be helpful to you out with this, I could give you a more practical detail of that.
Yes, it would be useful. I know lots of people relatives are in hospital and they scratch their head and get very worried about where my relative is being discharged to, and it's sometimes not really very close to them, and sometimes the placements aren't particularly appropriate. But obviously when they're under such pressure, by circumstance, you just have to do what you can do. Mm-hmm. Thank you.
Lucy.
Hi Alexis. So my question, I don't know sort of how much you can sort of say about this really, because my question is about the assurance framework, and obviously understand that the details of that are still unclear and emerging. But I suppose what I'm wondering is, with any obviously assurance frameworks can be a really valuable tool for sort of looking at what you're providing and how you're working and the sort of quality of provision and so on. But with any framework or inspection sort of setup, there's always a risk, isn't there, that actually people's attention gets drawn to bits of work that need to be done to get to tick the boxes, and sometimes that doesn't always align with actually what people are experiencing in real life. And I know that it's something that the CQC grapple with, and that they do try and look at real life experience in the context of those assurance frameworks, but I was just wondering what you were sort of doing in terms of the team that you're putting together to prepare for those frameworks, how they were sort of thinking about, how you were equipping them to keep the focus on the experience that people were having, as much as whatever sort of standards, tick boxes that need to be met in other respects. I don't know if that's, does that make sense?
It's a really excellent question, and it's actually one of the ones that I posed when this was first, when I read when it came about. And for me, what's been really important for me is to keep core to our change programme, core to what we are trying to do is people's experiences and views at the heart of everything that we do. And that includes the assurance framework and our preparation for that. Because for me, the test of how we're doing well is people's experiences of social care. And for me, that's what's always really important. And that's how you know you're doing well. If people are having good experiences and they're feeling positive about what they've received, then we know that people will have had a good outcome. So for me, in terms of the preparation, what we've been doing is linking into the national emerging picture around the assurance framework so that we could understand more about it and also benchmark. We've also been looking at the CQC well-led framework as a framework for understanding what that will mean for adult social care. In terms of the team being put together, what we have done is put a team together, but one of the key things for me was actually to link into Health Watch as the next key phase, so that we're actually making sure that people's voices are absolutely key to how we develop and prepare for the implementation of the assurance framework. Because as you say, it's not about ticking boxes. This for me is about ensuring that the assurance framework is very meaningful, and it helps to drive continuous improvement across adult social care services. And that's certainly the approach that we are taking within that. So hopefully that's quite helpful, and you'll probably be receiving quite a lot of invites quite soon after this, because there's lots of pieces of work that are just ongoing to try and very much take this forward in a positive, hopefully a very positive way for the people of Sheffield. And that was, for me, was one of the key aspects, is recognising that we're still very early days, but I think it's really important to be prepared now and have the conversations and talk about it now.
Thank you. Yeah, so we give a lot of feedback to the CQC, but also we have a lot of conversations with them about how they build feedback into the work that they do. So I'd be really happy to have conversations with you about how that might be factored into the work that you're doing.
Okay, Lucy. Any other questions from members? I have a sort of a tangential question about, it's to do with the under-occupancy of residential care. And I just wondered what the impact on self-fund, is there a negative impact on, how are self-funders affected? Are they more affected by under-occupancy than those that are council funded, or would you say, or it's a question I've had for quite a while now.
It's a really good question. I'm going to gather more data to give. I'll gain more information just to give you more comprehensive response out with this. But there is different. We have about 117 care homes across the city, and not all are funded by the council. Some are very much relying on people who self-fund. So it's quite hard to get a clear picture. You know? But one of the key things is that we have is we look at occupancy levels across the city, and for me, you know, what's really important is that we support all care homes, and because for me, what's really important is whether we fund or don't fund the care homes, is that residents' experiences and are consistent, you know, regardless of the funding mechanism, for want of a better word.
Yeah, just wondered, because the issue has occurred in the, last year in the hard peak of COVID, actually, but yeah. So I'm looking at Bernard, yeah.
Yes, looking at the framework, you say, talking about a workforce plan, and there's several things there. Incentives, for example, for working in social care. Have we got a baseline of what is actually happening there? Because I know in my role as a counsellor, I see so many people in uniforms going from one house to another. They seem to be under enormous strain. Do we have the sort of figures on what sort of stress they're under? Have we got measurements of how long they spend travelling from one place to another, how long they actually spend with their clients, and providing incentives for working in that environment, I imagine is going to be pretty difficult, given that that's the experience.
We've got a range of measures that we use that we work with providers with in terms of domiciliary care market. And I would say that we have a range of services across the city who really, who are striving to do absolutely the best that they can within what is sometimes very difficult circumstances. I think what's key for me is that we offer the support to the sector through this very critical time, and this is where the workforce plan has been really important to me, because one of the things that struck me upon coming to post was that we had no workforce plan for the whole of the sector, whether you be within the council or commissioned. And for me, I have an accountability across both, and it's important that we see the social care sector as one sector. And so that some of the data that you're talking about is some of the work that we're doing just now behind the scenes to try and get a baseline measure. And we're actually working with NHS colleagues with that as well, because for me it's really important that we see social care as not just a sector on our own, but also see it as part of the health and social care sector. The other key part of the workforce plan, which is quite important, is the career pathways. So that, if you start as a home carer, for instance, if you're 17-year-old, what I would really want to see is actually people have a career pathway. I started when I was 17-year-old as a home carer, and it's really important that actually people see that they actually have that career pathway in social care, and that they have that no matter where they start their employment with, and that they could have the opportunities for the future. And that's what will hopefully continue to retain staff within social care, because we have a high, unfortunately, there is people that leave the sector for various different reasons, and for me it's about understanding that, and that's where the data has came from that. And I could give you the data that we've got out with us, if that's helpful. Yeah. And but certainly for me it's been understanding the reasons why people stay within social care, but also the reasons why people are also leaving social care, and to look at then the practical things that we could do. And based on the conversation so far, part of that's been about the empowering our workforce through living wage, the career pathway, some incentivisation, but also the communications and the promotion of our social care workforce as well.
Thank you. I think the danger is that many people working in this sector do it because it fits in with their other caring roles, as it were, being there at the end of the day to provide a meal for their family when they come from. And my concern is that they get exploited with, and therefore, have to accept what is, a minimum wage. Is it £9.20 or something an hour or something at the moment? Which is, incredibly bad for morale.
So one of the key areas we're currently looking at just now is the national living wage, because that was increased as part of the review in October. So we're now looking at how we would implement that. The social care is a great profession to work within, and people in social care do such a great and valuable role. The living wage is really important, the career pathways, but also so is the value that comes into social care, and acknowledging and valuing social care workforce, I think, is really important as well as a city, and recognising the tremendous effort that social care workers right across the city do. And that value for me is also really important, and that people know that they are recognised for what they do. And as part of that, one of the key things for me is also about looking at a campaign for the city to value and to know that people are being valued for what they do.
Okay, I'm looking around for any other further questions or comments. Oh, yeah.
At the moment, social care is well overspent, isn't it? Yeah. How are you approaching, that? Because my son has just been reassessed and requires further input, but I know that there's financial implications on that. So how are you going to address that sort of problem?
So what we have to do is like every other social care service across the country, is we have to balance many things. What's a key priority though is that we focus on people's strengths and outcomes. And our approach is very much to have strength-based conversations with individuals so that we are approaching the support that we offer from the point of strength and from the point of view of the individual circumstances. And that's the starting point for our conversations with individuals. We have a whole different range of we have a range of proposals in terms of how we come to a more sustainable adult social care service for the future. And for me, what's important is, as part of that sustainability, is that we continue to make sure that we keep the outcomes and lives of people at central to what we do and going forward. And as part of the home care transformation programme, what's been really important to us is to actually have people's views and voices who use home care and also family members or carers being absolutely central to how we go forward. And that has really informed the different types of models that we need to deliver and deliver for the future. But it starts with the individual and their family member. That's helpful. I could certainly meet with you at Ruth if that's helpful as well.
Okay. Okay. I can't see any more hands. So, can we come to the recommendations then? We are asked, and I've lost it on the computer screen. Can you just read out the recommendations, Emily? Because my computer screen keeps going off.
Okay, so the Scrutiny Committee is being asked to note the introduction of an assurance framework for adult social care through the passage of the Health and Social Care Bill. Number 2, agree that regular updates on the implementation of the Adult Social Care Assurance Framework and Sheffield City Council preparations are provided to the committee, and agree that regular updates on progress of priority actions arising identified from the self-assessment are provided to the committee.
So, are members happy with those recommendations? Do you want to add, subtract, or accept them as they are? Are we happy to agree those? Agreed, then. So, can I thank you, Alexis, for staying all the way through as well. It's been very helpful. Thanks. So, we're still on the agenda. So, item 9 is a public questions report. Do you want to take that, Emily?
Yeah, sure. This is just a way of making sure that the response to the lady who came to ask her public question about the retendering of the carers contract at the last meeting, if you recall, we weren't able to provide her with a response at the meeting. We followed that up afterwards, and this is just a way of putting that on the public record. So you've got a copy of the response that was given to her, and I can update you that she has also had a conversation with the officer who was dealing with that process to kind of reassure her about some of her concerns. So they are in touch, and she now has a contact if she has any further queries. So I feel like we've kind of come to a resolution on that one. But if you need any more information or have any questions, we can deal with that.
Okay. So, over to you again, Emily, the work programme.
Okay, so you've got the work programme report. I think it was back in September, we talked about the development of the ICS, and one of the things you wanted to do was keep an eye on that as it progressed. So in the papers today, there's a proposal on how we might go about doing that. So it's, I'm proposing a kind of ICS scrutiny liaison group. So that's there for you to comment on, and if you would like to go ahead, it would be helpful if we could appoint a cross-party group of members to that today. So happy to take any questions or thoughts on that.
So, have we got any volunteers to be part of this? Ruth, are you is that your hand volunteering, or do you want to comment? Do you want to comment as well?
Volunteering.
Volunteering. Francine. I'm volunteering, and Emma suggested to me that I chair it, but I wanted to put that to members, whether they're happy for me to chair that liaison group. Are you happy with that? Have we any other? How many people are we looking at?
It's up to the committee really. It'd be nice if we could do it cross-party. If we can have kind of a range of councillors on there, but if in some ways the smaller the number of people involved, the easier it is to arrange meetings sometimes. So it's really if people have got the time to give to it. I'm imagining maybe a monthly meeting in terms of time commitment, but obviously I realise how difficult it is with members' diaries at the moment. Trying to organise things is very tricky. But we've got 3 there. That's if that's what we're dealing with. There are a couple of members not here as well. I can ask them if they'd like to.
Okay. Well,
Yeah.
Lucy.
Yeah, I think I mentioned before that I think we'd be interested in being part of it if that was appropriate.
Okay. Yeah. Of course. Yeah. Sorry, I've forgotten you, Lucy. So a big part of that. Yeah. Okay. So we have four then.
I'll ask Abtisam and Gary as well, and Vic, who aren't here today, if they're interested in joining, and I'll be in touch about the first meeting.
Okay. Looks as though we'll move forward on. Yeah. And thanks for putting this together, Emily. Thank you. Okay, so
Sorry, and just the work programme, the next meeting committee is scheduled for January, and we've got on there an update from the speech and language, the cleft palate and lip and disfluency service, coming back to talk about how things will look in the future following their change of heart on the service. I'm not sure how many members will have been around when we were doing the continence services work, but the CCG are going to provide a response to the recommendations in that report at that meeting as well.
Can I just say on the adult disfluency services, things are looking quite positive on that, and it shows how important the role of the Scrutiny Committee has been in influencing that change in the original decision. Anyway, just thought I'd comment on that. Alan.
Chair, has there been any thought for the March meeting? There's nothing there that's scheduled.
I think there's a list underneath of the kind of to be scheduled items. I know that councillors were keen to look at access to dental services, so that would make it a year since the committee's last update. But I'm just wary of putting too much in the work plan ahead of time, because something always pops up and throws us off. But if there are any suggestions or things people are particularly keen to see on there, it'd be useful to hear about it.
Just a quick question about the January meeting, the report on continence services. Would it be possible to have some background on that for newer members a bit in advance to look at? Thank you.
Sure, I'll circulate the scrutiny report in the next day or so you can all have a chance to look at it.
The other Ruth.
Thank you. I'd be keen to have a discussion on the mental health services suggestion that's in there. If that could be included in a future meeting, that would be of interest.
Sorry, in terms of mental health, it would be really helpful because it's such a big area of services and issues. If there are specific issues around mental health and mental health services that councils are interested in, it would be helpful to have specifics so that we can make sure that whatever report comes meets your needs.
Yeah, personally, I'd be interested in discussing the green prescribing and the role of nature in mental health.
I think we were talking about incorporating that in the after Christmas, basically. So. Right. Any other comments on the work programme? If not, can we accept that? I think that leaves us with the date and time of the next meeting. Oh, sorry. Thank you, pardon. I knew that was going to happen. Forgot the minutes. Can we move to the minutes then, please? Just on page 9. Okay, in case you've forgotten where it was. So I'll take it. Anything in terms of accuracy and any matters of arising at the same time for each page by page, if that's okay. So, anything on page 9? Page 10? Page 11? Page 12? On page 13, 14, 15, page 16, page 17, page 18, page 19, and page 20. If not, can we accept the minutes from the last meeting and move on now to the date and time of the next meeting? Are we happy with Thursday the 26th of January, 4 p.m. in the town hall, presumably? It'll be here again. So, okay. Thanks ever so much, colleagues. Thanks for your time and thanks for your contributions. And have a safe journey home.